We are making a difference.
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 We are making
a difference.
We are making a difference.
We are making a difference.
My name's Lisa Avery. I'm an obstetrician and gynecologist and an assistant professor at the University for Manitoba's Centre for Global Public Health. I oversee the maternal side of their maternal, newborn, and child health programs.
And I'm Maryanne Crockett. I'm a pediatric infectious disease doctor at Children's Hospital here in Winnipeg, and I also work at the Centre for Global Public Health, and I'm the newborn and child health expert on the team.
I think maternal, newborn, and child health has always been a development and global health priority. The world really brought international attention to it in 1980 with the launch of the Safe Motherhood Initiative, and then that's been followed up with numerous other development agendas, probably the most well-known of which would have been the Millennium Development Goals. And in choosing Millennium Development Goal number 4, which was to reduce child mortality, and Millennium Development Goal number 5, which is reduce maternal mortality, as 2 of the 8 goals, there was really commitment to make sure that the health of women and children was prioritized when it came to development. Unfortunately, despite that commitment, the progress had been quite slow in trying to achieve these targets. And in 2010, when the G8 summit was hosted in Canada, our Prime Minister, Stephen Harper, and the Canadian government really led the call to renew commitment and emphasis on this priority area. And it's something that's been incredibly remarkable, especially as Canadians, to see happen. From that G8 summit, the Muskoka initiative was launched, and that really brought global commitment again to focusing on improving the lives and outcomes of the most vulnerable women and children around the world. And it's been something that has been remarkable as a Canadian to see and witness, because it really put us at the head of the development agenda when it comes to focusing on women and children and their health. It's been something that has had an impact. For example, when the initiative was first launched, over 9 million children annually each year would die. And most recently, when the renewed commitment to this initiative was announced by the government in May of 2014, that number had declined to just over 6 million. It's still far too many, but it is evidence of impact that the Canadian government has been able to achieve or make through its commitment to this important area of development.
And I think one of the really exciting things is that in assessing how the Muskoka grants have gone and the commitment that was made, the government spoke to all sorts of stakeholders, including the Canadian public, and they resoundingly supported this, and that's led to the call for the second round of Muskoka grants and the large amount of funding, another $3.5 billion that the government announced in May at the meetings, and then now this more recent specific call, which is $370 million. So this is supported not just by the development groups in Canada, but by the Canadian public.
Globally each year, 289,000 women die from complications in childbirth or pregnancy, and many more actually go on to survive but have significant disability. Obviously, that's disastrous at the individual level, but it's also disastrous because the health of women is not linked just to the own individual's health, but also to that of her family, her community, and essentially her country. That's because if we look at the health of a mother, and I would argue the health of women in general, we know that it has direct impact not only on herself, but also the household and the wider community. For example, the health of a mother is a direct determinant of the health of her family and her children. We know that motherless children are 3 to 10 times more likely to die within the first 2 years of life compared to those who have mothers that are still living. And the majority of these deaths would actually happen within the first few weeks of life. If they do survive without a mother, the children are much more likely to be malnourished, to not have opportunity to attend school regularly, to not complete education, and to essentially continue to live in a cycle of poverty, which obviously has disastrous consequences for their future potential. The health of a mother also directly impacts the socioeconomic impact of a family. If you look at the income that's brought in by a woman in the household, it has 20 times more impact on child survival than that of a male counterpart. And it's because if a woman's healthy and able to work and earn income, that money goes to family welfare. So the woman is much more likely to spend it on things like purchasing nutritious foods for the family members, making sure that there's money for school supplies or school fees so that the child can be educated, and on spending money in terms of access to medication or medicines when there is a health problem within the family. That ultimately ends up resulting in healthier children and better educated children, who then grow on to become healthier adults and more well-educated adults, which results in more opportunity for them from social and economic and human capital perspectives.
So that's why one of the things we focus on in our projects is looking at a critical package of interventions that have been shown to save lives for women and children, not just for mothers, not just for babies or for children, but all the way through the continuum of care. So taking it through pre-pregnancy, into the pregnancy, particularly around the peripartum time when the baby is born, because that's when most women and 44% of children die in the newborn period. That's the first 4 weeks of life. Then all the way through young childhood and into preparing women to be mothers.
I think it's been well recognized that the negative effects of poor maternal, newborn, and child health reverberate across the household, the community, society at large, and the country, and that what really needs to happen in order for there to be sustainable economic and social development at the country level is a commitment to the human rights of women and children, so that there's a focus on gender and equitable access to care so that countries are able to develop and prosper in the way they wish to and aim for. The first thing we do is do an assessment of what the basic gaps when it comes to maternal, newborn, and child health services or availability or quality of services are. And then we try and prioritize based on that what a critical package of interventions could be and how to best deliver those to the population that are most in need. We really focus on equity, so we want to make sure that we're not just reaching the easiest people to reach, but the ones who are at the greatest risk of having a poor outcome and who are at the greatest need in terms of being able to access these critical packages. And then we make sure that while we're doing this, we actually critically assess whether or not what we're doing is working. And if it's not, we ask why, and we go back and redo what we've done or rethink what we've done. And if it is, we say also why and how can we build on this and share it with other programs or partners so that they can also learn from it.
The direct beneficiaries of our programs are generally the women of reproductive age and their young children. But really, when you think about the impact that good health among those women and children have on a community, on a family, it really is the entire community that benefits. So we think about, even though we've halved the number of child deaths since 1990, when the Millennium Development Goals are based on those statistics, every 5 seconds a child dies, under 5 in the world. And that's still far too many children dying.
After we'd introduced these job aids and tools, some of the staff nurses there said, before this program came along, we had women come in seizing from a complication known as eclampsia in pregnancy, and we didn't know what to do, and we'd watch them die. And since this program's been introduced, we've actually been able to do the correct treatment, which is administer magnesium sulfate, and we've seen them live and go on to have their babies. And that made us feel incredibly proud of our job as a healthcare provider, and that we were able to actually provide the service they came here looking for.
We had a symposium last year with a number of people who came from our projects, and the mission director from Uttar Pradesh came. And while the scale of that project is huge, Uttar Pradesh is a state of 204 million people, and we're working in 25 of the high priority districts. One of the things that he said is that we want every single mother that comes into a facility to be able to go away celebrating the birth of her most incredible special baby. So to take something from that scale and to understand that even though we're looking at it from a huge perspective from the top, we need to take it down to the individual mother and child and make sure that they get that care. We work with a number of partners. There are different partners in each of the projects. So in the Sukshema project in Karnataka, we work with KHPT, which is a Karnataka Health Promotion Trust, and it's a relationship or an organization that's been set up in relationship with the University of Manitoba and the government of Karnataka. In Kenya, we work with 2 different local partners. One is World Renew, which is an NGO that has offices around the world but has an office in Kenya, and also with Anglican Development Services Pwani, which is a local NGO in the county where we work, Taita Taveta County. And in Uttar Pradesh, we work with IHAT, which is the India Health Action Trust, along with a number of other partners as well.
I think one of the things that's been really lovely for us working on these projects is that we do have incredible teams on the ground that we work with and partner with, and who are equally as dedicated to making sure that the lives of women and children are improved through hard work and effort in these programs.
One of the exciting things that's happened somewhat in relation to the second Muskoka call is that we recently had a meeting of many of the Manitoba groups who are involved in development and health work globally, and it looks like we're in the process of developing sort of a Manitoba team or a Manitoba consortium of people who are interested in global maternal, newborn, and child health. And whether or not that translates into anything related to this grant, I think it has started discussion and collaboration, which may increase the footprint of what Manitobans can do to try and improve maternal, newborn, and child health around the world as well.
As Canadians right now, it's a really exciting time to be working in maternal, newborn, and child health, not just because of the commitment that our government has given and its continued efforts to focus on it as a priority area of development, but just as people, to see that we can make a difference and we are making a difference, even if it's one small step at a time, and that it's something to be proud of and to reflect on. I'm Lisa.
And I'm Maryanne.
And we are making a difference.